All right. Well, I will ease into things with a quick introduction and then we'll get started. So I just want to say a huge thank you to, we have over 20 attendees logging in right now, which is awesome.
Wow.
So oftentimes we'll get even more than that. So this should be a great presentation. So for those of you that haven't met me, my name is Jeff Gaines. I'm the Chief Medical Officer at Newport Hospital. And we've, in the past, pre-COVID, used to do these events live where we would sit with a panel of docs and have them give a little chat about what they do and what services they offer and what cool stuff is happening at Newport. And then we would serve drinks and snacks and people would mingle around and get a chance to chat with the doctor in a little more casual setting. So I super hope that we can get back to doing that sort of thing eventually. But in the meantime, until we get the green light to know it's safe to do that, we've switched this to virtual over the last year and a half or so. And we've had some great presentations. So I'm really glad to pull this one together because we have several of our esteemed orthopedic surgeons joining us today. And some folks out in the community may have heard rumors or things about what's happening with orthopedics, and is orthopedics getting bigger and better? Is it dwindling down? Are they closing? What's going on? So there's a lot of misinformation and some rumors. So I thought this might be a good opportunity to squash some of that and let you know that orthopedic surgery at Newport is definitely on the trajectory for bigger, better, greater things. And we're looking to grow and make things as optimal as possible with patient experience, giving everybody the best outcomes we possibly can. And we've tightened up our partnership with University Orthopedics. And so we have a few representation of those folks here on the line. So by means of a quick introduction, I'll just go kind of alphabetical order, but Dr. Gwen Bragdon is our chair of orthopedic surgery at Newport Hospital. All these docs are board certified, fellowship trained. She is fellowship trained in hand and microvascular surgery and really specializes in injuries of predominantly the upper extremity. So she did her medical school at Drexel University, then did her residency in orthopedics at the University of Rochester Strong Memorial Hospital, and then did her fellowship here at Brown in hand and microvascular surgery. And so she heads up our orthopedic surgery department at Newport. And then Dr. Ross Budaki, you can see him on the little screen there, also fellowship trained in sports medicine. So he takes care of the full spectrum of orthopedics, pretty much every joint you can think of, and everything from your sort of minor sprains and strains all the way up to complicated cases and trauma. Although we certainly hope we don't see too many of those, but it happens unfortunately in Newport when things go wrong. So he got his medical degree from Georgetown, then went to Einstein in Philadelphia to do his residency, and then did his sports medicine fellowship here at Brown, and still teaches as a clinical assistant professor at Brown. So we're excited to have him on board. And he's been here at Newport for a long time. So many of you will know both Dr. Bragdon and Dr. Budaki, longtime members of our medical staff. And then if we can get him into neutral and pulled off to the side of the road with an e-brake and his fancy sports car, Dr. Antoci, Val Antoci is also fellowship trained. So he really focuses on adult reconstruction, hip and knee total joint replacement. So he did his medical school at Jefferson Medical College in Philadelphia, then did his program at the Harvard Combined Orthopedic Program in Boston, did some training at the Harris Adult Reconstruction Fellowship at MGH, and then most recently at the Rothman Institute at Thomas Jefferson back in Philly, did some additional training. And he's very well known from his lectures. He's a big researcher, very academic, super smart guy, just like the other two are super smart men and women. So we are very excited to have the three of them really leading the charge along with Dr. Stabler, who is one of our orthopedic surgeons that also does sports medicine, trauma, does joints, does kind of the full spectrum. And then Dr. Jim Marr, who's been probably of the group the longest on the medical staff at Newport, and he's been in lots of leadership roles and really been a staple of the hospital. So University Orthopedics has been a longtime presence at Newport, just getting bigger and better, and we're happy to have Dr. Budaki join that group and Dr. Bragdon lead our department. And then if Dr. Antoci is able to join, he's recently become our medical director for our total joint program, which we're also pretty excited about. So without much further ado, that's kind of my intro. Maybe what I'll do is kick it to you, Gwen, since you're kind of the head of the shop. Maybe kind of give you a chance to speak a little bit about some of the stuff that you do both clinically and then, within University Orthopedics, some of the offerings and things we do at Newport. And then we'll see what Dr. Budaki has been up to lately. And then hopefully Dr. Antoci can join, and then we'll go from there. Sound reasonable?
Sounds great.
Awesome.
So as Dr. Gaines said, I specialize in the upper extremity. I do pretty much anything in the elbow, wrist, and hand, and I do some shoulder. I don't do arthroscopic shoulder, but I do fractures and other shoulder care. But anything from the elbow down, I do take care of. I also do vascular repairs and nerve repairs in people who need them. And those I will do pretty much anywhere in the legs or arm and decompress them if necessary. I trained in Brown and finished in 2008, and then went to Pittsburgh, where I did upper extremity trauma and upper extremity surgery for about 8 years there before we then moved here. And I've been here since about 2016 and really enjoying the Ocean State. I am at the office in Middletown on Wednesdays and Fridays to see patients, and I operate mostly on Tuesdays and every other Friday. But I take care of anything from upper extremity trauma, meaning fractures or ligament tears and injuries, tendon repairs, nerve repairs, and a lot of osteoarthritis of the hands is predominantly what I do. And some osteoarthritis of the elbow and definitely of the wrist as well. I also do treat the rheumatoid patients. I don't do the medications. I do leave that to the rheumatologists, but I do all the surgeries and have a great referral basis with the two rheumatologists that are close to the island. So.
Excellent. Well, we certainly appreciate all the cool stuff that you do at Newport. And I meant to mention that if you have questions that come up, and this is for all the attendees, I'm going to be tracking, there's a Q&A little bubble. If you're on a computer, it's usually at the bottom. If you're on an iPad, it might be at the top. And then there's a little single bubble that says chat. You feel free to pop questions or thoughts or anything you'd like to hear more about in either one of those. So I meant to mention that at the beginning. And then, Dr. Budaki, you pretty much do the whole gamut of orthopedic surgery. So maybe you could speak a little bit about some of the stuff that you like to do the most. And I know you've been doing some work lately with some of the schools and some of the sports stuff, which is pretty fun and exciting. So maybe you could kind of give us a little status report.
Yeah, so I've been down in Newport for the past 3 years, finished my fellowship in sports medicine at Brown, and then headed down to Newport after that. I've been seeing patients at the hospital and then also in our Portsmouth office location. With the new transition that's going on, we're no longer going to be seeing patients at Newport Hospital in the office, but we'll still be seeing patients in the emergency department and operating there. But I will be keeping my office in Portsmouth, so I'll be there 2 days a week, and then I'll be heading over to the office in Middletown as well too. So as Dr. Gaines mentioned, I kind of take care of the whole gamut of orthopedics, primarily focusing in sports medicine. So what that means is primarily athletic injuries and arthroscopic surgery of the shoulder and the knee. But then I also do general orthopedic care, fracture care, most things that you can think of, complex fracture care, polytrauma patients. Generally, we don't see those too much. If they're that complicated, they'll be transferred to the main hospital. But other than that, I take care of most injuries. That includes fractures, ligament tears, simple sprains and strains as well too.
Well, I can certainly speak as an emergency doc that had to call both of you at times. And it's nice to be able to have one of the two of you or your colleagues on 24/7, 365. Makes a bit of a challenging life for you guys, but it definitely makes a big difference for patients when they come in. And like Dr. Budaki said, we're not a trauma center per se at Newport. So if you're pretty banged up, especially if you have more than just orthopedic injuries, but you have other injuries as well, then often we'll move you up to our trauma center up in Providence. But for the most part, isolated orthopedic injuries and trauma, whether it can be managed in the emergency department and talking with one of these docs, or whether it's having them come in and either stabilize or sometimes take you right to the operating room, depends on the circumstances. So it's awesome to be able to provide that really anytime, day, night, no matter what, which is awesome for us to be able to say. And you can see that Dr. Bragdon's kind of specialties and Dr. Budaki's specialties kind of intertwine pretty nicely so that you get pretty much all the needs covered. And then, like we mentioned, Dr. Antocci is our medical director for the total joint program. So talking about more of your joint replacement surgeries, which is obviously a big topic. So we'll talk more about that in a little bit. But I was just curious, now we have total joint, we have upper extremity, hand, elbow down, shoulder, sports, things like that. Anything that you guys don't do at Newport, or that you either do other places or that we just flat out can't offer?
So Dr. Curris is going to be starting, I think this week, actually seeing spine patients once a week in our office. He'll be seeing patients on Thursday afternoons in our office. He does have a trauma a spine fellowship graduate also, who's going to be coming down to help him out when the volume gets a little bit too big initially. But he is going to start seeing patients and doing spine surgery out here as well. He also will be taking call, which will help us out, because spine is definitely one of those things that we have had a harder time having covered down here. But he's an excellent surgeon, and he really does a good job. And I'm glad he's going to be giving us at least one day a week down here. Foot and ankle. A lot of our docs will do a lot of the basic foot and ankle, fifth metatarsal fractures, and obviously any ankle fracture, but some of the more complex things, such as like Liz Frank injuries, which are bigger injuries to the foot. Again, we don't see that as much. And I don't think anyone in our group does bunionectomies. Ross, do you do those?
Yep.
No. So those are things that we would then transfer to our foot and ankle partners who are at East Greenwich. We are working on trying to get Dr. Blankenhorn or Dr. Sue to come out possibly one day a week, but right now that is the one thing that we just don't have on the island.
Yeah, the spine thing with Dr. Kuris is going to be a really great addition because, prior to this, managing spine fractures has always been a real challenge, or spine injuries in general, not necessarily fracture care. So we certainly have some of our other specialists. So our interventional radiologists will do some procedures for compression fractures, and we have some of our neurosurgical and physiatry colleagues that do some minimally invasive spine things. But from the orthopedic side, that was definitely a gap that we didn't have previously. So I'm excited to bring him on board. And yeah, the foot and ankle stuff I think will be really great to be able to offer as well. And I think we do have a good collaboration with some of our podiatrists that do some of those procedures, but some of those can be a little bit more limited. And as you get more complicated, it's nice to know that we have a kind of an entry point, I would say. And I don't know if you guys agree with that, but if somebody comes in, say, for example, gets to see one of you in the office and you decide this is something a little bit more complicated or a little bit beyond what you normally feel comfortable with. University Orthopedics is a pretty big organization. Maybe you could speak a little bit to sort of what access we have, because it's not even just in Rhode Island, they're up in Massachusetts. It's a really big organization. So pretty good chance we could find a specialist that meets exactly what you need.
So I would say that the one other thing that was a benefit that I meant to add is that Dr. Antochi is an excellent revision specialist for joints as well, which that was something that we were missing a little bit early on in the year, but he does a really good job with revisions, and he's very talented in that way. So that was something we did not have beforehand either. Pediatric elbow is one thing that a lot of doctors tend to shy from, and that's the one elbow I really try my best not to do unless I am really needed. But because we are tied with the docs at Hasbro, they're all part of our group. All the Hasbro pediatric orthopedic people are all in our group. They are able to help us out with pediatric stuff that we may not be comfortable with. That being said, I do a lot of upper extremity peds. I do all the hand fractures and wrist injuries for peds patients. But if it is a complex elbow or complex fracture of the wrist that may need a graft or may need an overnight stay that I may not be able to provide in this hospital, it is something I could transfer to one of our partners up at Hasbro. And I think that is definitely a benefit. Pediatric admissions are a little bit harder to do here. And that is one thing that I have transferred up if necessary.
Yeah, no, that's a great point. And, for those that are on the participants that you may or may not realize. So the emergency department, the operating room, we certainly have capacity to be able to manage kids. But on the inpatient side, if kids need to spend the night in the hospital, that's the one area that we used to do that to some degree. And then we kind of started doing just short stays, kids with dehydration and asthma and things like that. And then eventually it got to a point where it just made sense when kids are sick enough to be overnight in the hospital that we really ought to move them up to Hasbro. So we made that decision quite a few years ago. So that's a great point. Some of the kids, if you can get stuff done and not have to stay overnight, if it's relatively straightforward, then often we can take care of those here. But Dr. Badaki, what's your kind of lower age limit? You pretty much, I know you see a lot of the younger, healthier sports and athletes too. So.
So I see patients of all age, but if it's definitely something in the pediatric orthopedic specialty, I let patients know that I'm not a pediatric orthopedist, I'm a general orthopedist, so I can primarily take care of most fractures that kids have, up to things that include needed close reductions, which means kind of pushing on the bone or putting the bone back in place. But once it gets more complicated beyond that, that's sometimes when we'll refer them to the pediatric orthopedic specialist, especially if there's ever any concern that, if they needed to have surgery and they needed to stay overnight in the hospital, that's something that we would kind of guide them in the direction for that. But in terms of kids, I see a lot of sports injuries, like you said. One thing that I typically don't manage, though, is concussions in kids. I generally refer them back to their primary care doctor or the concussion specialists as well, too.
Great.
One benefit that we also have in our group that I regularly forget to mention is that we have Dr. Roy Aaron, who is an orthopedic surgeon who's now retiring into doing osteoporosis care. And he is excellent at helping to figure out why you're osteoporotic in terms of doing your blood levels for calcium and checking all your hormones. He is incredible. But what's nice is in his office, you also have the DEXA scanner and the ability to make the diagnosis and treat it. And he studies osteoporosis thoroughly and can get you on the right medications needed if necessary. And we have 2 orthopedic trauma surgeons who both trained at excellent facilities, and really for any of the major pelvis and multiple traumas, they are just excellent. And they also have a surgery ICU and a trauma ICU up north that we can send them directly to, which is helpful.
That's awesome. Yeah, I'm glad you mentioned the osteoporosis and some of those fragility fractures, because it can really be lots of different flavors where you get a break with what would seem like a pretty minor fall or some pretty minor trauma sometimes. So being able to find those out ahead of time is really key. And the DEXA scan, bone density, things like that are really key. And all the medication treatments to hopefully prevent future fractures if you've ever had one, or even sometimes prevent the first altogether. So yeah, it's definitely a good one, and kind of a good segue. I may kick this one over to Dr. Badaki, but there was a question about prevention. So, how do you, if you're pretty active, how do you keep your joints healthy and well preserved? And I've always sort of puzzled by that one. If you're a robot, the more you use the more you're going to wear out. And the more miles I have on my car, the more shot the parts get. But it seems like the human body kind of works the other way around. The more you use it, the better it seems to function within a certain amount, at least. So I don't know, maybe Ross, you could kind of bounce on that one. What do you kind of counsel patients in terms of prevention, staying healthy, keeping away from needing the folks like Dr. Antochi to replace your parts down the road?
Yeah, so I think, for the most part, it's just general common sense things. Staying active is probably the most important thing that you can do. Staying active by just simply going for walks, keeping a healthy weight, eating a balanced diet. These are all things that are good for your general health and also for your musculoskeletal health as well, too. A lot of times patients ask me, what can I do, in order to prevent fractures and things like that? From a standpoint of the non-medical side of thing, like I said, making sure that you're staying active, continuously loading the bones with exercise and things along that lines. In terms of fracture prevention, I generally will defer to the primary care doctors in terms of that. There's kind of an algorithm that we can go down that determines your fracture risk and things like that, and medications and what medications that you can take in order to help minimize those risks. But that kind of gets a little bit more heavy on the medical management side of things. And like I said, I usually will defer to the primary care doctors because these medications can interact with some of the other medications that they're on. And I think ultimately it's probably best handled from that standpoint. A thing that I always like to bring up with patients is when I see patients that have fractures, there's certain fractures that we see that can help us essentially diagnose osteoporosis just by the injury that they had. And I try and identify those patients and kind of direct them to their primary care doctor in order to obtain DEXA scans and possible consideration of some types of medications that can lower their fracture risk moving forward.
Excellent.
A lot of times in this area specifically, when people do load on the sunscreen, one thing is vitamin D replacement. People are taking vitamin D, but if it's not the activated vitamin D, it doesn't help build the bones as much unless you are actively getting sun. So that is definitely one thing. The studies are plus and minus on some of the other things, but taking something like an osteobiflex, which is called glucosamine chondroitin sulfate, that also, we think the minerals can actually help increase joint fluid and the buoyancy of the cartilage. So that may be a naturalistic way to go. Unfortunately, in this country, vitamins are not FDA approved. So because of that, I can't prescribe them, but I do recommend them in some people who have early onset arthritis. But I think vitamin D levels are something that the primary care doctors hopefully are following, because that is one way that we can naturally hopefully build bones as well.
Excellent. Makes sense. Another question that came up was about physical therapy. So kind of along the exercise theme, I know you often will utilize physical therapy both as kind of initial treatment for some injuries and an effort to try to treat them non-operatively. And then oftentimes in recovery after surgery, physical therapy is really key. So maybe each of you could kind of speak a little bit about kind of the role that you use in terms of physical therapy, occupational therapy, other sorts of maybe non-surgical treatments and post-operative treatments that you might provide.
Yeah, so as Dr. Gaines mentioned, I utilize physical therapy quite a bit, both our physical therapists and occupational therapists. At Newport Hospital, the occupational therapists generally see the upper extremity injuries and rehab situations, whereas the physical therapists will primarily do lower extremity. At least that's from my perspective. I know from the spine perspective, I think the physical therapist will see some of those patients as well, too. So I primarily send people to physical therapy kind of in two different avenues. One, as you mentioned, was post-operatively. A lot of times physical therapy is very important, especially after shoulder and knee surgeries, to help kind of maintain motion, kind of rehab the muscles and get back to full activity. The other time is for a lot of the patients that I see, non-operative treatments are the appropriate route. And a lot of times physical therapy can help kind of restore motion, improve strength, and then also stability about the joints. And many times, a lot of patients can avoid certain surgeries by maximizing physical therapy before considering, proceeding with surgery.
It always amazes me, if your muscle strength and support for your joints and your bones is really optimal, then it seems like you can absorb a lot of injuries and things that might otherwise hurt you, and just sometimes even pulling a suitcase out of the trunk of your car. It's like if you've done that at the gym 3 times a week for the last month, you're probably better off doing it and not getting wounded than if you haven't done it in 100 years. So it's my 2 cents, but I totally agree. I think that makes a ton of sense. Dr. Bragdon, were you going to add something?
Oh, no. So I'm sure most patients of ours are aware of this, but every university orthopedic office has their own physical therapist and occupational therapist. All of them are very well trained, but they work hand in hand with us. From a hand surgery standpoint, we meet with the occupational therapist 3 to 4 times a year, where we specifically go over new protocols, new ways of getting people their motion back faster. Specific fractures or specific ways that we've changed the way we do surgery. We go over the new protocols and how we want all of our patients treated, to kind of make sure everyone's on the same page. I work hand in hand with Kristen at Newport. She's the OT at Newport, and I work regularly with her to make sure she knows my protocols and what kind of splints we like. But a lot of things such as small finger ligament injuries and thumb arthritis, which is probably one of the most common things I treat. A lot of patients can get relief just by wearing a special customized brace for them. And if they wear that with pinch and grip activities or some of their activities, we can a lot of times avoid surgery, which has been great. And the one benefit is having the OTs directly beneath me in my current office is that if they're midway through a patient evaluation or they have any concerns, they know that my office is an open door. They have access to my cell phone. They can Teams me on the computer every day. But they also know that if they want me to come look at something right away, then they just come right up to the office and come get me. And that has been a huge benefit in this practice, just knowing and trusting the therapists and knowing that if they want my attention for something, it's important, I need to get down there and take a look at it.
It's got to be great for patients to be able to kind of get some one-stop shopping, if you will, while you're getting your therapy, and you have access if you need it for, more specialized care. And I would just like to point out that you use the expression hand in hand several times as a hand specialist. So I'll allow it a few more times, but it is kind of funny that you're the most qualified person to use that expression, I think. So.
I was trained by a Dr. Mitten. That was kind of wonderful.
Oh, that's good. That's good. I had my wisdom teeth removed by a Dr. Hackenberger. Wouldn't recommend that one. So
no.
sometimes some opportune names. That's funny. One other question that came in before the event that somebody sent me just to speak about is, and maybe falls in the category of stuff we don't do too much of from an orthopedic standpoint, would be cancer care. So obviously we have a relationship with the Lifespan Cancer Institute, and we do some cancer care. But that was one of the questions that came up is, do any of the orthopedic surgeons within University of Orthopedics, or specifically at Newport, tend to treat cancer patients, or do we tend to work with other colleagues up north, or how do you tend to handle those?
So I do treat squamous cell in the hand. I do treat a lot of hand surgery cancers. A lot of times if there is a lesion in the hand or wrist, the orthopedic oncologists don't want to do it, or they don't manage it. So especially for hand surgery, we're a little bit more specialized in that region, trying to figure out which joints we can save for pinch and grasp, which are definitely important. So yes, I've definitely taken care of multiple tumors and lesions in the hand. A lot of erosive erosive rheumatoid arthritis I do, things like that, which almost look like cancer. We do have Dr. Tarek up north who does oncology, and he is excellent. I can think of a specific pediatric patient where the patient really needed a major surgery. They were trying to save the limb initially. But I have a very good friend in Pittsburgh where I worked for years, who is actually a osteosarcoma survivor himself. And I called and I asked his recommendation because it was the same kind of cancer. And he asked me to call a friend of his in Boston. And we got the patient up to Boston. The patient has had great care. But that was the one time I've actually sent somebody up north. Every other patient has been able to be taken care of by Dr. Tarek. Or if it's in the hand or forearm, I will do them initially. And if it needs chemo or radiation, we then send that out.
Yeah, so from my perspective, just so for patients to know, it's actually very unusual to have a primary bone tumor. So the majority of the tumors and cancer treatment that I've encountered in practice and in training is primarily from metastasis from other types of tumors. So I have taken care of some of these patients primarily from the standpoint if they have spread to the bone and we worry that they're about to fracture through the area that's involved, or if they have fractured through the area that's involved. That's generally something that we can handle, at Newport Hospital. Beyond that, the patients that have primary bone tumors, as Dr. Bragdon said, we would definitely refer them up to Dr. Tarek. And then we do at times work hand in hand with the hematology and oncology colleagues in kind of discussions about, would this patient benefit from surgery? Is this something that's more appropriate for radiation therapy as well too?
Excellent. And I don't know, Dr. Bragdon, if you've been watching the chat box, but Heidi Moon put in a clarifying question. So maybe you could give us a little presentation on the vitamin D pathway and sunshine and how that all works, because I also find that to be a bit confusing and the different supplements are not equal to each other. So do you mind speaking a little more detail about that phenomenon and how sunshine makes your bones better?
Yes, absolutely. So vitamin D itself is taken by mouth in an inactive form. So we eat a vitamin D that's not able to work to balance your calcium levels and work with your parathyroids. And so what happens is it goes into your mouth and you eat it, and then it gets activated once in your kidneys and then gets activated in your skin the second time, which is how sunlight activates it. So when you go outside and you feel that sun on your body, not only does it make you feel better, but it's also activating and increasing your vitamin D levels. However, as doctors and especially plastic surgeons, dermatologists, we tell everyone, put your sunscreen on. You're gonna get skin cancer, and because of that, we have really pushed sunscreen. And what we have found is that by using sunscreen right away before you go outside for the day, we've really lowered people's vitamin D levels. And my vitamin D myself was very low, and it wasn't from sunscreens because I wasn't outside enough. And so now the new recommendations are, make sure you get a little bit of sun. If it's a sunny day, you only need about 5 minutes of exposure. If it's a gloomy day, they're saying somewhere between 10 and 15 minutes of exposure because the sun does still come through the clouds, and that should be enough to stimulate your vitamin D to change into an activated form where it can work in your body and in your system. That being said, some people who've had multiple skin cancers and other things cannot go without their sunscreen. And so you can buy products at the pharmacy that are vitamin D 1/1,3, and that is the activated vitamin D. The brand I tend to take is Caltrate because I know it's activated vitamin D, and it's been reliable. So I've taken that ever since I got my vitamin D level and found it to be low. And the supplementation does help. There are some people who have very low vitamin D levels. That's been a chronic thing over time. And sometimes when we are checking for osteoporosis or osteopenia and the blood levels are done and they have a really low level, some of those patients are put on very high supplementation of vitamin D. And that is something I usually, in general, will defer back to the primary care physicians or get their assistance with so we can get them on higher levels to get them bumped up faster.
All right. Hopefully, Heidi, that answered your question. So I think it's always one of those balances between not getting skin cancer, which you certainly don't want, but at the same time, you don't want to have not enough vitamin D and things to make your bones stronger. So that's really helpful. Appreciate it.
Yeah.
So that's a great question. So just to remind everyone, so that chat box works and you can see Heidi's question in there. We also have the Q&A box, which I have open and running as well. And then if you have questions, now is your chance. So I would invite you to take this opportunity to ask our orthopedic surgeons any questions that you might have, and they would be happy to answer them. And then I have a few others that people have sent me knowing that we were preparing for this little thing. So one of the big ones that I know we can talk a little bit behind Dr. Antoci's back a little bit about is our total joint program and what's happening there. So many of the community know that we had Dr. Mason, who came from the Baptist and helped us build up a total joint program. Dr. Mason has since moved his practice, and so he'll be moving over closer to South County Hospital, and they have some ambulatory centers there. And so while we love Dr. Mason and his program was really successful, we don't want to lose momentum with that. And so we're very excited to sort of shift gears, and that's where Dr. Antoci comes in. So I may ask you, Dr. Wagner, just to speak a little bit about that, but we've asked him to be the medical director for our total joint program, and he's been ramping up. I think he did 7 or 8 cases or something yesterday. He had a busy day in the operating room yesterday. So really up and running quite a bit with total joint. So I know there may be some misinformation that it's the total joint program in terms of whether it's happening or not happening and what we do. But maybe you could speak a little bit, if you could, to what some of the things Dr. Antoci does and what he'll be doing at Newport for the interim.
Sure. So Dr. Antoci's actually been with our group longer than I even have, and he's an excellent surgeon. He was operating at the Miriam in Rhode Island in the past, and coming out here one day a month when I was here in the beginning in about 2016. He was coming here about one day a month to operate, and just not being as busy here with Dr. Mason here. He's an excellent surgeon who does a lot of revisions and takes great care of patients, and does a lot of research and really keeps up on all the newer techniques and what's best for each individual patient. I feel like he really customizes care and does a great job of it. So when Dr. Mason was leaving, Dr. Antoci had already been coming out here once a month or twice a month. And so he was the natural transition to say, hey, can you bump that up? There's a lot of patients out here that need joints. You're already familiar with the hospital, familiar with the staff. And luckily he agreed to step in and kind of help keep everything going. With joints, that there's protocols for blood thinners and whether or not you need them after surgery, what kind of antibiotics you need, and all of these things change periodically. You really need to be up on the joint literature to know what is best and what the techniques and the protocols should be. And because of that, I think he is a perfect person to kind of take over that. He's always been on top of his research, always been on top of his studies. And he's able to help develop those protocols with Dr. Mason. They were both working on them initially together. And so I think it's a great jump start to just get his practice busier out here. He will still be operating at the Miriam and Rhode Island, but luckily he's going to give us more time out here.
That's great. Thanks, Gwen. Yeah, between what Dr. Antoci's been doing for a while and Dr. Stabler, they've both been really active with the total joint program. And Dr. Stabler doesn't do as much of the revision work, but does the primary joints, which is great. And yeah, to your point about him working at the Miriam. So having Dr. Antochi working at the Miriam, which is a really busy total joint program within the Lifespan system, that really gives us the opportunity to standardize as many things as can be standardized to make sure that we're really following best practice, evidence-based medicine, really everything from sort of prehab and education and how to use crutches and as many things as you can do ahead of time before surgery as possible to make sure you're as prepared and your expectations and what you need to do, and nutrition and your diet, and looking at diabetes and smoking and risk factors and all those sorts of things that we want to look at to make sure we're optimizing your chances of having no challenges, good outcome, good pain control, all the things that will help you recover quickly from surgery. And then, of course, the operative techniques and all the anesthesia and tricks like that, we want to make sure we're doing those that are right at the cutting edge of science to make sure we're doing the best thing. And then once you're done with surgery, we talked a lot about the therapy and working with the team and getting you up and about. And oftentimes we'll get people up and off the OR table in their clothes and get them dressed. And sometimes folks can actually go right home from the hospital the same day, which is remarkable. But it's amazing how well people do, especially with hips in particular, which seems like that would be a bigger challenge than knees if you don't know too much about it. But I don't know, maybe you could talk a little bit about kind of how that works if we do some same day surgery, if somebody comes in for a hip or a knee or something like that. Oftentimes they can actually go home, and you guys do some same day surgeries and things as well. So not everybody spends the night in the hospital.
Yeah, so predominantly in the the sports world, and essentially all of my patients are same day surgery patients. Very infrequently do I have patients that have come in for elective surgery and need to stay overnight. With new techniques and anesthesia and blocks, and which are kind of numbing the area for the surgery, a lot of patients are able to comfortably go home and with close follow-up as outpatient. Obviously, I do have some inpatients. Those are generally patients that are admitted through the hospital. But in terms of joint replacement, there are certain patients and there's certain people that are better candidates than others to be going home the same day after surgery. And I would ultimately defer to the total joint surgeons about who are the best candidates for that type of surgery.
I would agree with Dr. Badaki. They have a great method that all three surgeons have helped to build up, Dr. Mason, Dr. Antochi, and Dr. Stabler. And if you do pick a young, healthy patient who does have an easier house to get around, the physical therapists here have been coming straight to the recovery room and making sure you're safe and that they're not going to be sending anyone home too early. Just really making sure that you are comfortable, that they know what your home situation's like, and that you'll be going home into a safe environment and be able to get around on your own.
Yeah, it's pretty remarkable. And I think not too far from where Dr. Bragdon's sitting right now, there's like a little mini staircase, and people actually climb up and down stairs in the PACU and make sure that they feel pretty comfortable managing getting around their house. So to think that you go right from the operating room, anesthesia, having your joint replacement to, within a few hours, getting up and walking up and down a flight of stairs just sort of blows my mind. But it's the way we do things these days, which is pretty remarkable.
When I was in training, every ACL stayed for 1 to 2 nights, which I can bet Dr. Badaki's probably never even had to admit an ACL. It's very different.
Yeah, it's, as much as we like hospitals, and I'm obviously have some skin in the game there, my mantra is if we can keep people the heck out of the hospital, that's even better yet. And I'd be totally happy to turn Newport into a 8-story like med spa, cookie shop, bookstore. We'll find some other stuff. We'll figure out a different business model and keep people the heck out of there and keep them healthy. There's a question by Muna in the chat box just about sort of teaching and volunteering and shadowing and things like that. So I know each of you have some academic roles and things too that you've either done recently or are doing now. So maybe you could speak a little bit about some of the teaching that you guys do. And then if you could throw out there if you do any shadowing or volunteering, and then I can answer that one from the hospital standpoint as well.
Yeah, so when I was a fellow at Brown, I worked with a lot of the residents and some of the med students and doing some teaching from that standpoint. Starting in the next couple of months here, I'll be kind of working with the residents again, primarily up at Rhode Island Hospital. So a lot of times, patients will ask me, do I have residents that operate with me at Newport Hospital? I don't. I do all the surgeries independently down here, but I will be overseeing some of the residents up at Rhode Island Hospital. In terms of shadowing opportunities, it sort of depends on the individual. Maybe kind of each situation is unique. In terms of, shadowing opportunities in the operating room, that gets a little bit more difficult, especially because of patient privacy things and things like that. But we do have some PA students shadow us every once in a while. So that can be an opportunity. But I'll defer to Dr. Bragdon. I'm joining their group, so I don't know kind of what they typically do in their office.
So we did do some of that. All of that has been put on hold with COVID, especially with shortages in gowns and gloves and equipment. Believe it or not, even though COVID's almost 2 years in, we still have some shortages, even with gowns, I think, as of last month. So they really are holding back on having extra people gown up and be in the operating room. In Pittsburgh, I taught a ton. I taught the fellows and the residents. I had a lot of PA students and nursing students come through. Here at Newport, we do get a lot of scrub tech students, nursing students and PA students come through, and they have definitely followed me around and been in my operating room. Again, they don't operate on the patients. They're just there to watch. I had a plastics resident who came through who was more interested in hand, and he was working with the general surgeons, but then asked if he could come into some of my cases. And again, I'm very open with the residents that my patients were told I don't operate with residents, and so you can't operate on the patient, and I'm going to do the surgery, but you can watch what I do. And I've always been pretty strict with that. I've had 2 high school students come through my office to work with me. It's a busy day. They kind of run around all day. They've not allowed that since COVID, but if it's somebody who's trying to decide if they think they want to go to PA school, nursing school, I've had people ask, and then we usually run it by our chairman and see if it's allowed. And occasionally we can get approval with HIPAA and signing all the papers. I do know that people, in order to do that, have to be fully vaccinated, not for COVID necessarily, but for flu and all the other vaccines you get as a child, that you have to show your proof of vaccination to even get into an office to do that. Hopefully that will reopen in the future, but I'm not sure what they're going to do until COVID's kind of more nipped in the butt and they feel more comfortable letting people in and out of the office. Right now, our patients can only have one extra person come in, especially if they're discussing surgery, but they don't let whole families come into the office even now yet. They still limit it to one visitor if you're having a surgery to talk about surgery.
Yeah, it's the same restrictions, unfortunately, at the hospital, where pretty much, to Dr. Bragdon's point, initially, especially because of all the equipment and things, but also just, safety and exposure, and having more and more people coming through the hospital if you don't need them. There's always that worry that somebody has COVID and doesn't know it. And so we just want to minimize those sorts of things. So we'd love to get back to being able to have more people come in. But at this point, if you're a student and you have a really good reason to be working in the hospital, then we do have plans in place to be able to do that. But we also restrict visitation, and you can really only have one person at a time during certain visiting hours, even when you're an inpatient. So it's still frustrating and tight, but it's necessary, just because we do treat COVID patients at Newport Hospital. We have them on one of the floors of the hospital that's on the second floor on the opposite side of the hospital, not even in the same building as the operating room, which is nice. So from an infection control standpoint, when you come in and Dr. Budaki does your ACL surgery and you don't stay in the hospital overnight anymore, then you can come and go through the front entrance, go up to the OR, come back out and head out, and never go anywhere near the inpatient settings where any of that COVID patient population might be. So that's one thing I was going to mention to you guys too, just to get a sense of your pulse on things. Is obviously COVID's had an impact on everybody. And for a while, I know a lot of people were nervous about getting surgeries. And quite frankly, we called people and said, we're going to wait. We're not going to do your surgery because of COVID. We certainly test people now, anybody before they have surgery. We always test them to make sure that they don't have COVID, just so we can make sure that we can time it just right for them and make sure we minimize any complications. But I'm curious, your thoughts on the front end. You're the tip of the sword. What would you say to patients if they're a little anxious about COVID or anxious about the pandemic? Is now a good time to get your aching joints or your injured parts fixed, or would you recommend waiting a little while longer?
I think now it's safe. We do test everybody. Everyone in the hospital is vaccinated. Again, you're not going through the emergency room. You're not going through the patient areas where there is COVID. And everyone wears a mask. I haven't seen anybody without a mask the entire time. Patients have their mask removed in the operating room right before they get intubated if they need that. But even now, because of COVID, we do less intubations and less general surgery. We do a lot more surgery under blocks and a lot more under sedation, specifically to protect the lungs and to make sure that patients are being safer. Everything gets washed and sterilized in between, and knock on wood, but we've been going strong for at least a year or so now, and none of my patients have had any exposures or any complaints with the way things were run or completed.
Yeah, I think for myself as well too, especially my patients are same day surgery patients. They're coming into the surgery area, whereas Dr. Gaines mentioned every patient is screened, so we know that these patients don't have COVID essentially. And so then they have surgery and then they go home. So, it's, in my opinion, it's a very safe environment, especially if patients are already vaccinated. I think their risks of getting COVID would be extraordinarily lower than, doing general activities in the general population where you wouldn't know if patients are, screened as well too. So, from my perspective, I think the risks of COVID for having, a surgical procedure would be extraordinarily low.
Good. Yeah, I'm glad to hear you guys feel that way because, I've always tried to maintain the ready, safe, open once we got to that point in the pandemic where that seemed like the right thing to do. And you're right. I think, unfortunately, if you go to, the hardware store or the grocery store and other places, compare that to the hospital with all of the cleaning and the sterilization and infection control and screening and testing. And it's hard to find a place that's safer these days than being in the hospital. So I'm proud to say that we haven't had major issues, outbreaks, things like that. We've been really fortunate that things have worked out well. And so just to give everybody an idea, if you do end up having surgery, then the way we do it is if you're going to have surgery, say towards the end of the week, we'll have you come towards the earlier part of the week, usually a day or two before your surgery, and you can come get a COVID test right at the hospital. We'll make sure that you're COVID negative, give you a buzz with the results, let you know you're good to go. And if you are COVID positive, then obviously we'll walk you through. If the surgery absolutely has to happen, then we can be prepared to make sure we can manage things. But more often than not, if it's something elective, then it's actually better off typically to wait until you make sure that that's all cleared up, because you don't want to have any of the issues that COVID can cause in terms of surgery complications and things like that. And I know we've talked a little bit too about the vaccine, so I'm glad you brought that up because I think that offers another layer of protection too. So I'm guessing you recommend your patients get vaccinated. Any specific thoughts about if somebody's going to have surgery, when should they time their vaccine? Should they get it right away? Should they wait? What do you think?
I think the vaccine's more important right now. If it's an elective carpal tunnel or if it's a distal radius fracture or a hand fracture, especially if it's an elbow fracture, I would not wait. Tendon injuries, I don't wait on. But our recommendation currently in our office is not to do surgery in the first 4 weeks after your vaccine. Some of that's petered out now to be about 2 weeks for more minor surgeries, but major surgeries, they're saying wait 4 weeks after the vaccine before you have your major surgery. Again, that being said, any fractures, tendon injuries, nerve injuries, anything urgent, you should get taken care of, because a fracture that's been sitting in the wrong position for 4 weeks is a lot harder to fix and doesn't necessarily have the same outcome as if you have it done in a timely manner.
Yeah, like so many things in medicine, it's always one of those challenging balancing the risks and the benefits of all your decisions. So bottom line, my recommendation is if you're not sure, then talk to Dr. Bragdon, talk to Dr. Budaki, kind of help if you have time to decide these sorts of things and it's not an emergency or an urgent thing. Then, in my mind, if you're getting prepared for an elective surgery, it might make sense, if you haven't already, to get the vaccine, get yourself protected, wait the appropriate amount of time to make sure your body's responded to the vaccine and you haven't had any issues. And then, especially if you need to have a bigger surgery like Dr. Antochi would do, where you might need to stay overnight in the hospital for a knee or something like that, then I think just it gives you the extra layer of safety of being vaccinated. But if you haven't yet gotten your vaccine, if you're not planning orthopedic surgery, then go right now, log off this meeting and run out and go to the pharmacy and get one, because it's definitely getting us out of this jam of the pandemic we're in. But there might be circumstances where these docs would recommend getting your bones or your parts fixed first. And then we don't typically give the vaccine while you're in the hospital, because some people will get that immune reaction to the vaccine and they might feel shaking, chills, and even get a little bit of a fever and feel crummy. And the last thing we'd want to think is, oh my God, do you have some sort of surgery problem or complication or infection? So in order to avoid that one, we will typically wait for a little time after surgery too, if we can, before we recommend you get your vaccine. So. All right. Well, we have a few minutes left, and there's a couple more questions that came up. One, Holly put in, will Dr. Antochi be joining? And I think he's been having some technical difficulties. So I will use that as an excuse to ask Dr. Antochi to come back. And we can do a specific little meeting with him if people are interested, because I think that will be great. But unfortunately, he's been having some challenges. And then we have an attendee in the Q&A section, which I'll click the little answer live so you guys can see it. But I'll read it in case you can't pull it up. It says, I've had major knee surgery at Newport Hospital. Why isn't there better coordination between physical therapy and the surgeon while rehab is underway? This person went through 16 sessions of PT and still haven't heard if the surgeon knew what progress was made, and then adjust the physical therapist to concentrate on areas that needed it. So it sounds like not a great experience in terms of PT and following up with the doc. Maybe you guys can speak a little bit to that. And then when Dr. Antochi has his little session, we can ask him that same question. But any thoughts about that sort of interface between PT and how they communicate information and follow up to you guys?
Yeah, so, I work with the physical therapists at Newport Hospital pretty regularly. It's been, extremely convenient being like physically in the same location as them. But we have, very open lines of communication. I talk to them on a daily, if not maybe weekly basis, maybe not for every single patient, but anytime concerns pop up, they know pretty quickly how to get a hold of me. So generally it's, I haven't run into those issues too much. If there's been like an access problem or something like that, like I said, I try and keep open lines of communications between the patients, physical therapists, and myself.
I predominantly only work with the occupational therapist. Occasionally I'll get a physical therapist working with me, but Kristen is the main occupational therapist, and she knows how to reach me. She does mostly reach me in Epic, which is something I log into at least every other day. I'm not on it every day. So sometimes if I'm in a really busy Wednesday office, I may not get her message for about 48 hours. And so she knows to call me if she needs me right away. And that's been working. There are some therapists who do try to reach me and probably some of the other doctors via our Lifespan emails. The Lifespan email system is very well protected because hospitals have gotten hacked before, not Lifespan, luckily, but when a hospital gets hacked, it's a big problem from a HIPAA standpoint. So the firewall to get into Lifespan emails from my house, or if I'm on a vacation, can be extremely difficult. We had some difficulties when we were in Nantucket this summer, trying to log into patients' charts, and we figured out a way to do it, and it was a matter of logging into our cell phones as the main way, and not logging onto any Wi-Fi systems. But both my husband and I were having some difficulty with that. So in those cases, I did lose some of the emails for 4 or 5 days. Again, I always make sure the therapists know that they can reach out and call me, or if they call my office will find me right away. Things can sometimes be difficult to find in Epic, so I've specifically notified the therapist to write me an Epic chat, so that way it alerts me that it's there and I know that. I really feel bad for your situation and what you went through with your knee. That is not a good situation. My concern would be that your notes were getting filed somewhere into Epic, and that maybe the doctor or physician just didn't know how to access those, because Epic does change its format periodically. And when that happens, it takes us a day or two to figure out where everything is again, and things luckily, hopefully don't get missed. But again, open communication with the therapist, I think, is a must and necessary, especially for hand, wrist, and elbow. Elbows can be very finicky. So I think as long as the doctor is open and talking to the therapist, that's what needs to happen.
Yeah, I would echo what Dr. Bragdon said. Just I'm sorry that you had that experience, and it's certainly not how we would want that to go. So hopefully, going forward, I haven't heard too many situations like that. I agree with Dr. Badaki that both the therapists that work in the hospital proper, both in the inpatient and outpatient setting, as well as the therapists that work in the orthopedic offices, they're oftentimes almost co-located with the docs, or in the same location or in the same place. So that's unfortunate. I'm sorry that happened. And I would definitely encourage you to advocate and be the squeaky wheel. Oftentimes, if you let the physical therapist know that you have concerns and want to make sure they're communicating with the surgeon, I would say to almost everybody I can think of, the therapists they all have my cell phone number. I think they probably all have your cell phone numbers as well, to try to resolve issues and things. And so I'm sorry if you had that experience. And then, obviously the surgeon ultimately owns things too. So I would definitely recommend that you reach out to the surgeon as well, and just make sure that, if they don't have the information, especially with a knee, because for all the joint programs and things, they actually track a lot of that data to make sure that you did well. And we report that information as we go for accreditation and awards and things like that. So not that us getting awards is the important piece, but it's really making sure that we have the best possible outcome. So I'm guessing that information and the data is out there and people are looking at it, but it just may not have connected in the way that eventually circled back to you. All right. Last couple of minutes before we wrap up, and I do want to be respectful of your guys' time. So I see Dr. Bragdon is still trying to finish up her day in the OR too. So I'll kind of do a little round robin for you guys. Any closing comments or thoughts, things that you'd like the community to know about kind of what you guys do or what services you offer, or Newport Hospital, or anything else that's on your mind for the community lectures?
So I think, we've been communicating a pretty good job, at least for my current patients that I have, especially, I'm going to be transitioning from being at the hospital to working for University Orthopedics, but hopefully from a patient perspective, there really shouldn't be, much of a hiccup. I'm essentially finishing one day and starting the same day, so there shouldn't be too much of a gap, in transition. And I think we've sent out letters to all the patients, maybe here and there. Not every patient's getting it, but we're trying to do the best job we can to let everybody know about the transition. But just so everybody knows, again, I'm still going to be seeing patients in the same office space that I've been seeing them in the Portsmouth office. Going to be there on Mondays and Fridays. And then instead of being at Newport Hospital for office hours, I'll be also, in addition to Portsmouth, in the Middletown office where Dr. Bragdon currently is.
Valley Road.
Yeah, 45. I would say that we're working really hard to make sure that all services are covered here. We are pretty specialized, each and every one of us, because we're fellowship trained. And although we may span other parts of the body, we do tend to have specialties. So we've worked really hard to get everything out here so that everyone can be treated on the island who wants to be treated on the island. I would urge anyone who's had a bad experience, like the patient with the knee, just speak to your surgeon. We're all approachable. Every one of us that's coming out here is a good guy who really wants to listen, that wants their patients to do well. So I think if you talk to us, we'll reach out to the therapist and say, hey, I haven't found your notes. Can you tell me where they are? But don't ever hesitate to talk to your doctor, and make sure that if you think we're missing something, we need to know that. I'm always able to be talked to, and if you think I'm missing something, I want to know that, and I want to make sure I'm finding the information I need on you. So. Yeah,
absolutely. So, well, thank you for being receptive to those sorts of things, and hopefully that those circumstances are pretty rare, as they certainly seem to be from my perspective. But even one time, we always like to make sure we address those things. So certainly feel free to reach out to me as well, especially if there's anything that has to do with the hospital or the services that we provide. We always want to make sure we're doing the best we can and make the place as good as possible. And hopefully you've heard tonight that you get the best of both worlds. You get the fellowship trained experts that'll be doing your actual surgery, and so don't have to worry about trainees and people that aren't real experienced working on your body. But at the same time, know that the university and University Orthopedics doesn't mean they're still going to school. It means they're teaching at the school, and so you've got the experts right here at Newport, which is pretty exciting. and pretty much the full spectrum of orthopedic care from the top to the bottom. And regardless of injury and illness, there aren't too many things that we don't take care of right on the island, which is pretty exciting, both in the hospital and in the offices, as well as the therapy and all the things you need on before and after. So pretty full spectrum of things. So I just want to say a huge thank you to Dr. Bragdon and Dr. Badaki for joining this community lecture and taking the time out of your busy schedule. Much, much appreciated, and even more so for all the hard work and all the patients that you take care of, both in the office and at the hospital. It really means a lot to me and means a lot to the community. And to the community, thank you for jumping on these lecture series. Hope you learn a little bit about what we do at Newport and some of the surgeons that we're proud to have on our staff. If you do have questions about University Orthopedics, if you have questions about Newport Hospital, please go to newporthospital.org, which is our website, and you'll see links, finding a doctor to the different services. You'll see links to Newport Orthopedics, to University Orthopedics, to the offices, the phone numbers. And then this session is recorded. So if you found it to be really helpful, you can reach out and we can send you the link and the information, or if somebody that you know wanted to catch it didn't have a chance, then we can send it to them as well. So until next time, I'll say goodnight, and we will try to get Dr. Antochi on. Maybe we'll do a little solo performance with him, or maybe he and Dr. Stabler can do a tag team in the next few months. So I'll reach out and see if we can get that working, because I know you'll have questions for him. And then we've got a few other tricks up our sleeve, some other topics that have been popular that have been requested. So we will see you at our next virtual community series next month. But thank you, Dr. Badaki. Thanks, Dr. Bragdon. Really appreciate it.
Thank you.
Thanks, everybody. Have an awesome night.